case of CA oral cavity, a female Mrs. X, aged 73 years, in Pune, and who's a male patient, Mr. X, aged 73 years, hailing from Pune, is a shopkeeper by occupation. He presented to us with the chief complaints of non-healing ulcer in the left side of the oral cavity, which was noted since 6 months, and history of left cheek swelling since 2 weeks. History of presenting illness: the patient was apparently normal 6 months back when he noticed an ulcer in the left side of the oral cavity, which was initially of 2 into 1 centimeter in size, insidious onset, and gradually progressed to the present size of 3 into 4 centimeter. He also gives history of left cheek swelling, which was insidious in onset and has not progressed much since the time he has noticed, since 2 weeks. Patient does not give any.
Dishita, one second.
Yes.
Madam, we have to say inside of the cheek or outside? Cheek means, do we have to mention where cheek, inside or outside?
Yeah, I didn't want to interrupt her, but oral cavity is a big subsite. What is oral cavity, Dishita?
The whole, it starts from the lip, vermilion border of the lip, extending up to the anterior tonsillar pillar.
It comprises so many subsites are there, no?
Yes,
so when
yes,
you say left side of oral cavity, we won't get an idea. So if it is buccal mucosa, you tell buccal mucosa. Okay, buccal mucosa means inner aspect of the cheek. Okay. Then later it has progressed to involve the skin outside. Okay, that way you can tell. So don't tell oral cavity because it's a big subsite. Okay, you have to specify the lower jaw, upper jaw. If you want to tell in patient's language, you tell like that. Okay. Or onto the if you are telling RMT, it's more onto the posterior aspect, as patient said. Okay, so since they cannot have the RMT. Okay.
So, patient was apparently normal 6 months back when he noticed an ulcer on the posterior aspect of the left lower alveolus, initially of 2 into 1 centimeter size, and gradually any altered sensation over the face or on the left side of the cheek. No history of trauma. No history of any caries or any dental procedure being done. No history of fever. No history of increased salivation or any hoarseness of voice, no history of any speech difficulty or swallowing difficulty. Patient does not give any history of loss of weight or loss of appetite, no history of chest pain, breathlessness, hemoptysis, or jaundice. With patient is a known case of asthmatic since childhood, not a known case of diabetes mellitus, hypertension, or tuberculosis. No history of undergoing any surgeries in the past. No history of undergoing any hospital administration in the past. Not on any medications. Patient diet is mixed. Personal history: diet is mixed, appetite is good, bowel and bladder normal and regular, sleep sound. Patient gives history of tobacco chewing, that is slave climb with tobacco for the past 40 years, which he has quit 2 months back. No history of associated smoking or tobacco consumption. Family history: patient does not give any history which is relevant to the present conditions, nothing significant. So with this, I would like to summarize. 73-year-old male patient presenting with a non-healing ulcer in the left lower alveolus and later extending into the inner aspect of the left cheek for last 6 months, and with history of left cheek swelling for the last 2 weeks, and with a positive history of tobacco consumption for the last 40 years.
So you a little bit of mistakes are there in your presentation. Okay. So we'll see from the first. Okay, just go to the first page. We'll not spend today much time on history because we have already discussed it. Okay, but I'll tell you where you have made mistakes. Then next. Okay, so onset, progression you have told. Okay, you told it's a painless swelling. Okay, did you tell?
Yes, ma'am. No history of any association with pain or.
Okay, so and you have ruled out the infective causes, right? So
Yes, ma'am.
now, so since you're telling posterior aspect of the lower jaw, okay, you're okay in asking there is any difficulty in swallowing or like that, okay. Salivation is accepted because secondary to irritation and secondary infection might affect saliva, but it is more common in tongue, okay. Ear pain more common in tongue, but you can still ask, okay.
Yes.
Difficult mouth opening is relevant here, okay. What are the causes of trismus? Trismus is painful or painless, or it can be both.
It can be both depending upon the cause for the trismus. If it's an inflammatory cause, it can be painful, but if it is a chronic because of submucous fibrosis or because of a malignancy, then it might be painless.
So if it is involving, it is because of the involvement of pterygoids, okay. Secondary to any neoplasm, it can be painless, okay. But if it is any inflammatory cause, as you told, then that can be painful, okay. So, grading of trismus, what is that grading called?
Khanna and Khanna classification and Zoma classification.
Yeah. So, can you tell me?
More than 35 mm entrance insider distance is grade 1. 35 to 25 is grade 2. 25 to 15 is grade 3. Less than 1.5 mm is grade 4.
What are you talking distances?
Sorry, ma'am.
What distances you are mentioning?
Voice is breaking, ma'am. Voice is not audible.
Inter-incisor distance.
Yeah, it is inter-incisor distance. Is my voice breaking, ma?
Now it's okay, ma'am.
Okay, fine. So why did you ask about hoarseness of voice, Dishita?
One doubt, madam. One doubt. If the patient is pedunculous, then this we have to mention inter-incisor. Alveolus se ho jayega.
It will be alveolus.
Okay.
It will be alveolus. Yeah, tell me why hoarseness of voice?
Because he also gives a history of tobacco chewing and everything, so there might be any associated second primary lesion as well.
Okay, fine. So, what dental procedures? You have mentioned this in present history only. Okay, fine. Then see, more common is pulmonary distant metastasis, jaundice, and all won't come. Okay, whatever is relevant, you tell. Okay, because then again drag you why jaundice in oral cavity cancers and all. Okay, so just
one day you told that dental formula. What is that? The simple that which you use dentition formula. You told one day to read, na? What's some dental formula?
Yeah.
Okay, that thing only, na?
Okay. 2, 1, 2, 3. So
okay, madam. Okay. Relevance, madam.
You have to know about the missing treatment.
Okay, fine.
Its relation to any, where is the lesion and all. Okay.
Okay, madam. Thank you, madam.
Next, Dishita.
Yes, ma'am.
So, in this surgeries, more relevant is only any dental interventions. Okay.
Yes.
Rest all things are not relevant. Next. So, in this, very important thing you should always mention is, okay, in head and neck, the habits might come in present history as well. Okay. So, if you want, you can elaborate them in personal history, but a chronic tobacco chewer, okay, and very important when he's taking, you told again no tobacco consumption. So even chewing tobacco is tobacco only, okay.
Yes.
So don't make that mistake. Second thing is, whenever he's chewing tobacco, how many times he's chewing tobacco in a day, how much time is the contact time, means how much time he's keeping it in mouth and spitting out. Okay, these two things have to be mentioned when it is chewing tobacco. Okay, if you want to tell other forms of consumption of tobacco, like smoking is not there. Okay, so that makes sense. Okay, see, no smoking or alcohol you wrote. Okay, fine. No other addictions, but just modify your sentences.
Yes.
I know you know, but don't commit mistake of saying no tobacco usage. Okay, even chewing tobacco is tobacco only. And okay, no family history. Next.
That's all, ma'am.
That's it, na? So okay.
Ma'am, I mean this tobacco, because it's a head and neck case and it's a CA oral cavity. Should we mention tobacco chewing in the initial sentence itself, like a 77-year-old man?
Yeah, a chronic tobacco used to chew tobacco since 10 years, presented with this and this complaints, is also fine. Okay. So, and the details of the tobacco consumption, I would like to elaborate in personal history. If you tell that also is fine. Okay. So, if you can just mention he is a chronic tobacco chewer, so which itself states etiology. Then, yeah, fine. Next, proceed, Dishita. We have to discuss today reconstruction. We'll concentrate on reconstruction and anatomy. Okay.
Yes.
Of all the subtypes and reconstruction. Okay. In general. Yeah.
73-year-old male, moderately built and nourished, conscious, cooperative, and well oriented to time, place, and person. Examined in sitting position with natural light, exposed up to the clavicle. BMI 22, ECOG score was 0. No pallor, no icterus, no cyanosis, no clubbing, no generalized lymphadenopathy. Neck lymphadenopathy I'll be discussing separately later. No pitting pedal edema noted. And on inspection, patient in the sitting position under good natural light and exposed up to clavicle. Facial symmetry was noted with the fullness of the cheek on the left side, reaching up to the zygomatic process, and also another fullness noted in the left submandibular region. Skin overlying this, there was no ulceration, no erythema, no redness, no scars or no sinuses were noted. On asking the patient to clench the teeth, deviation of the left angle of the mouth was noted. On proceeding to the examination of the oral cavity, on proceeding to examination, mouth opening was 1.5 finger. Loss of tooth of right central incisor and the lateral incisor was noted, with halitosis noted. Oral hygiene was poor. So, teeth were stained with tobacco. Oral submucous fibrosis changes noted with fibrotic bands on the right side has
Wait, ma. Okay.
Yes.
So you told facial asymmetry. Then what you should tell?
Facial asymmetry, any skin changes on that side?
All that things. Next, what in oral cavity examination? What are you supposed to tell first?
Mouth opening.
And
Then?
hygiene also.
Oral hygiene, halitosis, stained with tobacco.
So lips. First is lips.
So dark stained lips. Dark stained lips.
Fine. Yeah, it's not smoking, so be careful. Okay.
Yes.
Yeah. Then first you'll tell about mouth opening. Then you'll tell about lips.
Halitosis.
Then you tell about teeth.
Mouth opening, halitosis, hygiene, oral hygiene, and the teeth stained with tobacco. And next, coming to if there is any pre-malignant lesions or any leukoplakia, erythroplakia, or any submucous fibrosis changes noted. And then coming to the lesion proper.
Yeah, and all the subsites after you tell in detail about your lesion, then you have to mention other subsites also. If you can mention name by name, then tell rest of the oral cavity examination was normal. If they ask you what all you have examined, then you should tell. Okay?
Yes.
So now you tell about the lesion. Okay?
Yes. So on examination of the lesion, solitary ulcer noted occupying the region of the left RMT, extending antero-inferiorly from the second molar and antero-superiorly extending almost 4 centimeters from the angle of the mouth. The superior extent of the lesion could not be appreciated since the mouth opening was restricted. Posteriorly, the lesion was seen to occupy the whole of the RMT. And the margins were irregular, edges were everted, floor of the lesion was formed by the slough. On examination of the other subsites, there was no any other lesion noted in the other subsites.
So was it any bleeding was visible?
No, on inspection, no bleeding was noted.
Okay. Anything else you would like to say?
Loss of tooth I've mentioned, ma'am. No sharp tooth was noted.
Okay, tell what all teeth were lost also. That's important.
Yes,
okay.
Yes.
Were they
yes.
near your lesion or away from the lesion of interest?
They were away from the lesion. There was the right central incisor and the lateral incisor.
Okay. Then? Yeah, palpation.
On palpation, the inspectory findings were confirmed on using a tongue depressor to retract the cheek and examine the lesion completely. No tenderness noted. Bleeding on touch was present. The lesion size was confirmed, extending from the left RMT antero-inferiorly from the second molar and antero-superiorly 4 cm from the angle of the mouth, and superiorly involving the upper GBS as well, and posteriorly antero-inferiorly involving posto-inferiorly involving whole of the RMT, and the posterior extent superiorly was extending up to the GBS but not reaching up to the alveolus, and the margins were irregular, edges were everted, floor was formed by the slough and partly by the tumor tissue, and base was formed by the buccal pad of fat laterally, and inferiorly it was formed by the mandible at the region of the RM. And
so this lesion is in. Could you see and palpate any space in between the lower alveolus and the lesion, or it was completely obliterated?
There was a space, but it was extending from the RMT involving the GBS going to the up into the buccal mucosa.
No, what I mean to say, is it in contact with the lower alveolus and upper alveolus, or you couldn't find anything? It was abutting.
It was abutting the lower alveolus, but not the upper. Upper, it was just reaching up to the upper GBS, but not abutting the alveolus.
Upper was reaching the alveolus, but not reaching in the RMT.
Yes.
Okay, fine. So, what is RMT? Okay, fine. You completed your palpation or anything else?
On palpation of the other subsites, there was no lesion felt or no nothing felt. On ideal examination was normal. And next, coming to the examination of the neck,
skin infiltration.
The lesion was reaching on the intraoral examination. The lesion was reaching up. The base was formed by the buccal pad of fat. Externally, on examination of the skin of the fat, the skin was pinchable, non-stretched, no tenderness, no erythema was noted.
Okay.
On examination of the neck, fullness noted in the level submandibular region with skin overlying it was normal. There was no scars, no sinuses, no ulcerations was noted. On other regions of the levels of the neck, no fullness was noted or no swelling noted. On palpation, a solitary swelling of 3 into 3 centimeter or spherical in shape with irregular borders, hard in consistency, fixed, non-tender, noted in level, submandibular region. Examination of the other levels, there was no any other swelling noted in the other levels.
So you can tell it as lymph node, ma. You are referring to lymph node, no?
Yes, ma'am.
So tell it as, because swelling gives us another impression. Okay. Okay. In inspection, you can tell as fullness, but when you are telling palpation, you tell it is a lymph node. Okay. You are referring to lymphadenopathy only, no?
Yes, yes.
Okay. So, how far was this from the angle of the mouth? The lesion was starting opposite which molar?
Okay, the lesion was occupying the submandibular region at the level of the angle of the mandible, and the mandible could not be felt separately from the lymph node. It was a hard.
I'm asking the primary was how far from the angle of the mouth?
From the angle of the mouth, 4 centimeters.
4 centimeter. Okay. And reaching the RMT. So it was almost starting from second or third molar and reaching RMT.
Yes, ma'am.
Okay. You told something like deviation of angle of mouth, if I'm not mistaken.
Yes, ma'am. Yes, ma'am.
So what do you think is the reason for that?
The large node which is there in the submandibular gland, which is hard and fixed, so might be the marginal mandibular nerve might be involved.
Marginal.
So little unlikely. That's why I asked what is the distance from the angle of the mouth. Okay. So okay, fine. If it's not, it's rare, but it can happen. Okay. So tell me what is mastigator space? You're done with the examination?
No,
Other system is normal.
Other systemic examination normal. Ideal was normal. I would like to give the diagnosis of a malignant ulcer involving the left RMT extending into left buccal mucosa and upper GBS with a level 1B node with a staging of T4A and 3B.
Okay. So you're...
Madam, ideal we have to tell madam this because we don't have...
You have to tell ideal for every case because of what? Field cancerization. Okay. So...
But we don't have that... instrument there.
I couldn't do an ideal because the things were not provided. That you can tell, okay, in exam.
We can tell that,
yeah. Ideal has to be mentioned, okay.
But the trismus ideal was possible, huh?
Sorry?
Here the trismus is grade 2, no?
Yeah.
Ideal so we can defend because of trismus we couldn't. Otherwise we could have done.
Yeah.
In this case, we can still do ideal.
मैम ट्रिसमस इसमें इतना नहीं है कि हम लोग आइडियल ना कर पाए.
It is quite open to the extent what I can see. It's not that severe grade of trismus. You definitely can do an ideal. Yes. Stroboscoping is definitely possible. Okay. So,
ma'am, I had
loss of tooth, madam, significance.
In this case, you tell me it is away from the site of the lesion, isn't it? So it's not very significant. Okay, if it is at the site of lesion.
How the loss of tooth happen, ma'am? That I think we should ask, because if tooth extraction के बाद हुआ है कि it's automatic patient lost a tooth or any history of trauma.
Yeah, she told that there were no dental interventions and it should be some spontaneous loss.
Ma'am,
I don't know. Apart from Avneet, I will tell you.
Apart from if somebody asks us in exam, how can you clinically tell that the buccal mucosa or lower alveolus lesion is involving the bone? So other than having disease on both sides of mandible, what other signs are we supposed to say that can help us elicit involvement of mandible?
What will happen if the mandible is involved? Last time we discussed, I think.
Loosening of tooth.
What will happen? There will be broadening of
nerve involvement can happen.
Nerve involvement is late. But what happens initially? First of all, there will be no on examination. There will be no obvious normal area between the lesion and the mandible. Okay, and the mandible, there will be broadening of the alveolar margin. Then what will happen? There will be loosening of teeth or loss. There will be loss of teeth. Okay, loosening or loss. There will be fracture. Okay. So these are all the clinical signs, and as you told, nerve infiltration and neuropathies. So these are all features of clinical features of mandible involvement. Okay. Otherwise, you have to
How
confirm it.
is widening elicited widening of the?
So what happens in this when the lesion is infiltrating? Yeah? So normal, you can see the difference between the normal area alveolus and broadening of this alveolar margin, which is at the site of the lesion. Why? Because it's trying to expand. What are the like ways in which mandible can involve the? In which mandible is involved? What are routes of entry?
Abutment and occlusal, ma'am. Indentate, it is indentate, it is abutting, and indentate,
Line of
it is
abutment.
occlusal.
Tell me, there are 7 routes.
Yes.
Whose paper?
Brown set out.
Yeah, tell.
So one is periodontal, one is occlusive surface, one is through the mental foramen and the mandibular foramen.
One from neck side, Ehlers node, as in your case.
Next.
And after chemo RT, maybe from the cortex directly.
Cortical bone defects, and then gingiva.
Within cortical surfaces. So you told edentulous, you told break in cortical surfaces, you told direct invasion.
Yes, ma'am. And the 2 foramens, mental and the mandibular foramen.
Yeah.
Occlusal surface.
Yeah. Through the nerves. Yeah, and out submandibular infiltration. So these are the routes. So whenever it goes inside, no, it tries to expand that area and cross onto the other side. Okay. So because of that lesion trying to infiltrate through and through that area, I mean that alveolar surface from the buccal surface to the lingual surface. Okay. So there will be broadening of that area of the alveolus compared to the area which is not involved. Okay. So that is the reason. And what is masticator space, Dishita?
Masticator space is a paired cervical spaces which is present on the either side, which contains the masticator muscles.
Can you tell me what are all masticator muscles?
Medial pterygoid, lateral pterygoid, the masseter, and the temporalis muscle.
Okay.
And it also contains mandible and mandibular nerve, blood vessels, and the lymph nodes and all.
So you are telling this is cervical fascia inner layer, okay, which extends from. It extends deep to medial pterygoid and attaches to the skull base. Okay.
Skull base. Yes.
Median to what? Foramen oval. Okay. Then what are its contents?
Its contents are of the masticator space, ma'am.
Yes.
It contains 4 muscles. That is masseter, temporalis, medial, and lateral pterygoid. It contains mandibular nerve, then one bone, that is mandible, and then the vessels, internal maxillary artery, and then it is again subdivided into. Yes.
Okay.
And
so,
Ma'am, temporalis muscle also, madam?
It engages a cervical fascia inner layer, which encloses all the muscles of relation. Okay. So,
masseter space, but temporalis muscle is going up where, you know, madam? It is going into supratemporal fossa.
No, temporalis muscle. Okay. Temporalis is one of the muscles of mastication. Okay.
So, below mesenteric space. Below zygomatic arch.
I'm asking
masticator space.
Asking masticator space. Okay.
Yeah, but temporalis muscle will go very up, na, madam?
Temporalis muscle, कैसे बताऊं? Masseter will be onto outside. Okay. Medial pterygoid will be onto the other side. In between will be the temporalis muscle.
What I understand, madam, from this masseter space is ITF plus masseter muscle. What I remember. If we are to define masseter space,
below the arch part will be there, na? As mandible itself is there, so temporal.
Below, and that is below zygomatic arch.
Yeah.
But temporal muscle will go up, na, if I'm not wrong.
No,
part of it is
temporal muscle thing will come in between medial masseter and medial pterygoid. Okay, and from above it will come. That is skull base. Means this space will be extending medial to the foramen ovale. Okay, and outside will be masseter.
Medial one more doubt I have.
Yeah.
Ma'am, I read somewhere it was written that masticated space involvement makes the disease T4B. Is it so, ma'am?
Yeah, it is in T.
Yes.
Yeah, that is the problem. Okay, so but it does not have same prognosis like because we can resect it. Okay,
It comes under a resectable T4.
Resectable, yeah, but it is included in T4B, but it has good prognosis compared to other unresectable areas. Okay, so that is the problem with the staging. Okay, previous staging which they are following. Okay, so tell me what is RMT?
Okay, ma'am.
RMT is a trigon-shaped space which extends anteriorly from the last molar and posteriorly reaching up to the ramus of the mandible, formed by the ramus of the mandible.
So last molar, ascending ramus of mandible,
Temporal ridge, I think, ma'am.
maxillary tuberosity. Okay. Then yeah. So what is ITF? Hello.
Hello.
Yeah. Tell me boundaries of ITF.
It is extending superiorly up to the skull base, laterally by the medially by the pharyngeal wall, laterally by the ramus of the mandible.
Superiorly by greater saphenous bone, medially by lateral
Pterygoid plate. Laterally ramus of mandible, inferiorly open रहेगा.
Masticated space which is not there in ITF. Hello?
Yes, ma'am.
So, which muscle it doesn't include?
Masseter.
Yeah. So, it excludes masseter. It ends at the mandible. Okay. So, mandible, medial pterygoid and skull base. Okay. So, yeah. Both okay. First, we'll tell the boundaries in detail. What is there at what is anteriorly to ITF?
Maxillary sinus. Posterior
surface of maxilla and infraorbital fissure. Okay. What is posterior?
Posteriorly is parapharyngeal space, carotid.
ITF का posterior क्या है? Tympanic portion of temporal bone and mastoid. Okay.
Superiorly, the base of it's formed by the base of the skull, the sphenoid bone, straight out in the sphenoid
portion of temporal. Okay. And what about yeah. So
laterally, it is formed by the ramus of the mandible bone.
Ascending ramus of the mandible. So what are the contents of ITF?
ITF contains basically these muscles of mastication, excluding the masseter, and it contains the internal maxillary artery, the division of the terminal branches of the external carotid.
Mandibular nerve.
See, it contains one nerve Sorry,
Mandibular
nerves.
nerve.
Okay. Mandibular branch of trigeminal nerve, V3. Okay.
Yes.
That is
Maxillary artery.
5-3. Okay. And chorda
Maxillary
tympani branch of facial nerve. 2 nerves. Okay. And venous plexus. That is pterygoid plexus.
Venous plexus.
1 artery. Okay. Internal maxillary artery. Muscles. Temporalis, medial and lateral pterygoid. Ganglion. Otic ganglion. Okay. Like that. 2 nerves. 1 artery. 1 vein. 1 ganglion. 3 muscles. Okay. It will into ITF. So, what is speciality of this retromolar trigone, Nishita?
It can
Ganglion will be pterygopalatine, na? Pterygopalatine ganglion, na?
otic ganglion.
Otic ganglion.
Otic.
Yeah. Why is eye special subsite?
Because it can extend. So, RMT is a bad subsite among the considered among the other subsites because it opens up to a spread into multiple regions. Like it can go into the ITF, it can go into the buccal mucosa, it can go down into the mandible, and medially it can go into the oropharynx as well.
Yeah. So it doesn't have much of osteal barrier. Okay. So it can easily reach the skull base. Okay. So that is a RMT. So now, what do you want to do in your case?
In this patient, I would first like to confirm
Okay. One more question before that. What is high ITF and low ITF?
Radiologically, when we see the condylar and the coronoid process, anything above that, when we see it becomes a high ITF, and below that becomes a low ITF.
Notch. Above the notch.
Above the notch.
Sigmoid notch. Okay. So, what is the importance of this high ITF and low ITF?
In low ITF can still be considered as planned for surgery, as it is a borderline resectable, can still be planned. High ITF is usually considered a contraindication.
Which subset does bad?
High ITF is bad because it's difficult to get a margin.
So, what do you want to do in your case?
In this patient, I would first like to confirm my diagnosis and get a H biopsy or a punch biopsy to confirm my diagnosis. Followed by to know the local extent of the disease, I would like to get a CT paranasal sinuses and neck. CT head and neck.
You would like to get what?
I would like to get a CT head and neck.
CT neck. Okay. It will include oral care. The extent which you cover CT from? If you ask for a
I would should I cover from the paranasal sinuses or the base of the skull till the clavicle.
Above base of skull, below till clavicle. Okay.
Clavicle.
So, actually, you need to measure head and neck. Head and neck they will include brain. Okay.
Yes.
फेस
So,
हम लोग फेस एंड नेक
neck
लिखते
include-
हैं मैम.
We write as PNS and neck.
Yeah.
Only then they come.
If you want the PNS cut, you can write face. Okay. But
Yes.
if you write head, they will do the brain. Okay. So that's it. So what do you want to see in that scene?
I would like to know the extent of the lesion.
And we have to say na ma'am puff cheek part, puff cheek.
Yeah. See, with a puff cheek pattern. Okay. So why puff cheek?
So that the GBS and the vestibules are well appreciated when the puff cheek is given. Of course, it's difficult to differentiate the buccal mucosa and the GBS from the alveolus.
Yeah. In your case, it's almost involving, so it may not make much difference. But generally, when buccal mucosa is there, purely buccal mucosal lesion, do tell in puff cheek, with a puff cheek, this one. ECT. Okay. So yeah, what from starting you want to know? Tell everything.
In this question, first I would like to know the extent of the location and the extent of the lesion superiorly, whether it is involving the ITF or the pterygoid plates or the pterygoid muscles, and inferiorly whether the mandible cortical erosion is present or not, and the medial extent as well, and soft tissue extent to note radiological depth of invasion in the buccal mucosa if it reaches up to the subcutaneous part of the skin. And I would also like to know if mandibular foramen is widened or if the nerve is involved. I would also, followed by this, I would like to know neck, if there is the lymph node status, if there is any other lymph node, and if that node is again eroding the mandible.
How much time break?
No, I am free. Okay. What are on your CT imaging or otherwise clinical?
Right.
What are signs of inoperability?
Okay, if you're waiting for some of your colleagues to join, we can wait for 5 minutes.
On the CT, if there is pterygoid plates involved, then it is an absolute contraindication, or if with the skull base or the prevertebral fascia is involved posteriorly, or the mediastinal structures or extending into the lower neck disease which is involved in the mediastinal structures, then it would be inoperable. Otherwise, if it is only the pterygoid muscle involvement, then in selected patients we can still operate.
Then we can start.
Clinically,
Okay, yeah, go ahead.
medially, if it is extending into involve the base of tongue or the oropharynx, then it is inoperable. And
Past theory.
I'm so sorry to just cut you in the middle.
Edema?
Just make it full screen.
edema, if it is extending above the zygomatic arch, then it is high likely to be a high ITF involved.
Ma'am, is the involvement of lateral pterygoid and temporalis equal to high ITF involvement?
Lateral, yes. Lateral pterygoid.
Lateral, yes. Medial is still resectable, but lateral, you will not get the margin. Okay, but still,
So, ma'am, lateral pterygoid and temporalis, if are involved, we will not consider the patient for surgery.
No, we can consider. That's what we can clear. But if it is like low ITF, okay, so we can get the margin still. But sometimes if it involves high ITF, they need a skull-based resection. Okay, so and very likely that they will recur. Okay, so you will not get a negative margin. So that's that for the examination purpose. The involvement of lateral pterygoid is more dangerous than a medial pterygoid. That you should know. Okay. And literally for our examination purpose, you tell when lateral pterygoid is involved, I will prefer giving NACT. Okay. So and then resect. Okay. Then yeah. So
both will be relative, na? Like you said, because lateral pterygoid ke bhi there are two heads, na? So if the inferior head is involved, we can still probably get a margin. And medial pterygoid maybe if the medial most head is involved, then parapharyngeal space में entry होता है तो थोड़ा margin का issue आएगा. ऐसा ही कुछ रहता है.
Lateral क्या ऊपर से ऊपर रहता है. Plate to condyle it will come that. Sorry.
नहीं, lateral और medial दोनों की तरह two heads. तो lateral में जैसे एकदम तो ऊपर वाला head रहता है, that is the sigmoid notch वाला head. तो उसके ऊपर गया तो you are definitely unresectable.
तो मेरे को जहाँ तक याद है lateral का एक superficial जो head रहता है वो अपन पढ़ते हैं plate to coronoid वाला. उसके ऊपर वाला तो deep वाला तो और भी ऊपर रहता है. तो it is high ITF anyways. तो lateral is high ITF. NACT देना पड़ेगा.
So yeah, whenever it's going beyond sigmoid notch, no, so it's better not to take it's better not to operate and to give NACT. Okay, so for our examination purpose, whenever it is lateral pterygoid is involved, we will give NACT. Okay, so for our examination purpose, practically it is possible to resect, as you said. When it is below the level of sigmoid notch, you can still go and resect, but for examination purpose, you tell I'll give NACT, okay, to get the margin.
Okay,
then yeah, so Next, what will be the approaches? Do you know any approaches, Dishita, for ITF clearance?
No.
Just the names. Okay, they may not go in very deep to ITF and all. So there will be anterior approach, inferior approach, lateral approach. Okay. So again, craniofacial resection is the other one. Okay. So just remember this. Anterior approach means you will go either through transoral route or through the maxillary transantral route. Okay, antrum. And or the palatal route. Yeah. So that will be the anterior approach. Inferior approach means through mandible. Okay, transmandibular or transcervical if you go. Okay, lateral means through zygomatic. Okay, zygoma or temporal bone scissor. Okay, and lateral others will be facial-maxillary, craniofacial resection. Okay, yeah. So you just remember the names. That's it. Okay. Yes. So yeah. Now, what do you want to do? Like, okay, your lesion was take. We will discuss 3 scenarios. Okay, wherein it is involving the maxilla. Okay, wherein it was involving the low ITF, and where only mandible is involved. Okay, 3 scenarios we'll discuss. Okay, so that we'll discuss the reconstruction part of it. Now, first, suppose it's involving only the mandible. Okay, your it was just reaching the upper alveolus. Okay, not involving the upper alveolus, only involving the mandible and RMT. So, what will be your approach to resection in this case?
In this patient, I would
mind you, I think your patient had grade 2 discharge. Okay?
Yes, ma'am. Yes, ma'am. Hello.
Yeah, tell me. I'm listening.
So in this patient, since the patient has trismus as well, and there is mandibular invasion and also the buccal mucosa lesion reaching up to GBS, for the primary resection, I would like to do a lip split incision. Raising the flap, the cheek flap, reaching upwards, followed by a segmental mandibulectomy with a composite resection of the primary with a 1 centimeter margin.
It was abutting the upper alveolus, but not infiltrating. Would you like to address anything there?
We can
take a margin of the upper alveolus as well. Okay.
Ma'am, on the skin side, skin was shiny na with edema. So on the lateral side,
skin was pinchable. So
margins we take buccinator muzzle or
we take.
So whenever the skin is stretched out, so that means the buccal pad of fat is breached. Okay. So, but skin is pinchable. So you have to see through your imaging how much extent is involved. It might need the dissection of the skin as well. Okay. So your reconstruction should cover that as well if it is involved. Okay.
Yes.
So regarding your mandible, what you will do, Dishita? Regarding your maxilla, in this case, which I told first, only mandible is infiltrated. Mucosa, it is just abutting onto the alveolar surface of the upper, this one. And skin is, don't say close. Okay, it is just onto the inner aspect. It is involved, buccal mucosa. Outer is free, skin is pinchable. So what do you want to do in this case?
In this patient, composite resection with segmental mandibulectomy, since the mandible is involved. And for the upper alveolus, I would like to take at least the outer cortex of it, the margin of upper alveolus as a bony margin. And if we are able, if the skin is free and if the margin is present laterally, reaching up to the buccal fat with the adequate margin, soft tissue margin, you would like to do a composite.
How much mandible you took resection?
Just the posterior segment of the mandible.
Posterior segmental mandible.
Lateral. Yes.
Okay. Posterior segmental yours is involving RMT.
Yes, ma'am.
Okay, fine. So posterior segmental would be ideal in that case. And okay, so what do you want to, like, how much margin will you take?
1 centimeter margin, gross 1 centimeter margin.
Okay. What is difference between specimen directed margins and patient directed margins? Which is preferable?
Specimen directed margin.
So, okay, gross 1 centimeter you told. So, how much should be pathological free margin?
5 mm.
When is it threatened or closed, and when is it involved?
If it is less than 2 mm, then it is close margin, and or it is a margin positive.
Is it 2 mm?
Then it is 1, less than 1, 1 to 5, more than 5.
It is 1, not 2. Okay, 1.5. Okay, less than 1, that is 0.5 centimeters, 0.1 centimeters. Okay, more than 0.5 is clear. Okay. So, yeah.
Bone is also for bone, madam.
Bone gross 1 centimeter margin you have to take. Okay. It is also for bone, but to the gross extent of bone involved, from that area you have to at least resect 1 centimeter. Okay. 1 to 1.5 centimeters if you go, then final the fixed specimen you will get 0.5. Okay. How much time will they take to give bone report, Dishita?
Usually takes 7 to 10 days for the bone reporting, for the decalcification to be done.
So they decalcify. So
Can we send the marrow for confirmation frozen?
If you are planning for a posterior segmental and you have features of any neurovascular bundle involvement, then definitely you have to send. Okay. If you're planning for a hemi, then nothing. You directly do a hemi. Okay. So,
Madam, यहाँ पे there is RMT involvement. So, are we okay with posterior segmental? Because RMT में where will be your proximal? If you are considering 1 centimeter.
If you ask me, then I would prefer hemimandibulectomy in this case. Okay, hemimandibulectomy is marginal or mucosectomy at least if it is abutting. Okay, upper alveolar mucosa and or a marginal resection with if it is close to skin, then skin excision of the skin as well, with reconstruction with a bipadal flap. Okay, that's
why hemimandibulectomy, ma'am.
Because in our institute also our boss says the same.
RMT is involved.
Condyle preserving.
Yeah.
Condyle we can preserve, no, ma'am.
Yeah, we preserve the condyle and then remove just that segment, and then we put a plate over there, L-shaped plate.
That's why I didn't tell no to the posterior segmental mandibulectomy, but RMT is quite a risky lesion. Okay. So, because the infiltration will be way beyond what we see. Okay. So, on imaging and all. So, for RMT lesion, it is risky. Okay. But still, it's not wrong to say if you are doing a condyle preserving posterior segmental mandibulectomy, but safer option would be a hemi. Okay. So, because RMT has it has more extent of invasion rather than what we see on imaging or clinically. Generally, RMT lesions infiltrate more because of the lack of barriers. So, it's not very safe to do a posterior segmental mandibulectomy unless you are pretty sure your margins are negative. Okay. So my preference in this option, this one will be like hemi. Okay. But if you are pretty sure that it is not, as per what you told me, it is involving the ITF and all. In that case, definitely, I would prefer a hemi. Okay, so no doubt. And suppose, okay, it is involving both maxilla and mandible. Then what do you want to do?
a wide resection involving the infrastructural maxillectomy, composite resection of the buccal mucosa, as well as the segment or a hemimandibulectomy.
Bite resection, you told, right?
Yes, ma'am.
What is bite resection? Again, hemimandibulectomy.
When we remove the inferior bony margin, as in the mandible, as well as a part of a maxilla, along with the soft tissue between it, that is the buccal mucosa and everything, the complex is called as a bite.
That is called bite composite resection. So not separately. Okay. Yes. So it includes both mandible and maxilla. Okay. So
If the mucosal lesion is just abutting the maxilla, not invading, then are we doing just alveolectomy or should we do intratemporal?
No, if it is just abutting, it's not needed. You can just remove that mucosectomy, it is called, okay, or marginal resection you can do, but not needed to do infrastructural maxillectomy. Okay. So if it is infiltrating the maxilla, then definitely infrastructural maxillectomy with hemimandibulectomy as a bite composite. Okay, complex. So reconstruction, you tell me, ma. In these three cases, what suppose skin is involved? First, let us take it's not involved. Okay.
Yes, ma'am.
Then what are your preferred options? Only mandible is involved, maxilla is not involved. Then second is maxilla is involved. You have done an infrastructural maxillectomy with hemimandibulectomy. Then third one is both are involved with skin involved. So what are your preferred options?
So in the first scenario where the mandible is involved and is abortic the upper alveolus, if you have done a osteosegmental condyle, if you are able to preserve the condyle with the margin of the upper alveolus, and if it's a fit patient with no comorbidities and a good performance score, we can as well consider a pre-fibula graft or pre-fibula pre-flap, or a PMMC flap. It's not a fit patient, or if there's not a condyle preserving, hemimandibulectomy with the margin of upper alveolus has been removed, we can consider a PMMC flap as a pedicle flap.
So yeah, they might be pedicle flaps or free flaps.
Free flap.
Okay. What are the options available for pedicle? PMMC, you told one.
Yes.
Anything else?
Pectoralis major osteocutaneous.
If it is a smaller defect or not much of a bulk is required, then even a temporalis flap can also be considered.
Not a very good option. It's little disfiguring, na? So,
yes,
yeah. Then, anything else?
What about pectoralis major osteocutaneous? Myo-osteocutaneous.
LDB
PMML. Yeah, it's one option.
Did they do that? PMMC osteocutaneous?
I've seen PMMC osteocutaneous in middle third. I haven't seen in hemimandible, but
because
middle third mein agar karte hain, so I'm assuming
It's very far.
The vascular supply to the bony becomes risky in that case.
I haven't seen one. Okay. But if you want to be safe and you want to do a pedicle flap, PMMC is fine. Okay.
PMMC.
And
DP can be same.
Sorry.
डीपी में बल्क नहीं रहेगा स्किन
There
के
is
लिए
if you need a bipaddle, then it is you can do a composite like 2 flaps. Okay. If it is you can do a free flap with a PMMC cover, like composite flaps. Okay, that's one option.
पीएमएमसी चला जाए फ्री फ्लैप चला जाए एलडी भी पहुंचा सकते हैं ना एलडी फ्लैप
Yeah, LD also is an option. But so okay, you tell me what all if you're considering for reconstruction. So what all aspects you will consider?
The condition of the patient, associated comorbidities. If it is a diabetes, hypertension, then atherosclerosis also. We need to do a Doppler before to check the perforator status. and the overall performance status of the patient, the cost factor being explained to the patient.
So you will consider the general condition of the patient. You will take into account the functional. So whatever flap you are putting, they should serve physical function, okay, as well as psychological, nutritional, okay, and it should be with good quality of life. So if you are, as in like if you are considering temporal facial flap, no, so it is little disfiguring. So quality of life is disturbed. Cosmetic is not there. So these cosmetic, considering the physical condition of the patient as well as the functional status of the patient is very important. Okay. So whenever you reconstruct, what are your goals of reconstruction?
To provide a cover, bulk, and also the cosmetically good and a function of the function, as in the patient should be able to have a good quality of life for.
So it should be aesthetic, it should restore the contour, okay, it should be cosmetic as well as it should be functional, like oral competence and all should be there, as well as it should serve if in case mastication, all the functions, whatever that particular area is involved in. So what is reconstructive ladder?
Reconstructive ladder starts with initially for smaller lesions, like doing a skin grafting or split skin grafting can be considered.
Reconstructive ladder starts with primary closure. Then
primary closure. The next would be a skin grafting, and then is the local flaps. Then comes the pedicle flap, and then the free flaps, and then the free flap with with bone.
Local flaps, regional flaps, distant flaps, and free flaps. Okay. So you have to consider both donor side patient factors, donor factors. I mean donor side any morbidity is there, and what is the amount of defect you should cover. So you will take into account what skin, soft tissue, and mucosal reconstruction. Okay. So skin grafts may. When do you think you can do a skin graft? In head and neck. Okay.
Yes.
So where all a graft is, what are types of skin grafts?
Full thickness and the split thickness.
Okay. So what is the difference?
In split thickness, only the epidermis and the part of dermis is removed, while in full thickness includes the epidermis as well as the dermis.
Okay. So what are full thickness grafts? Where are the donor sites generally?
From the supraclavicular fossa, groin, or from the buttocks.
Anything in head and neck?
Preauricular region.
Yeah. So even you can take from the tip of the nose, lower eyelid. These are all of full thickness only. This one. What is the problem with grafts? Why are they not so considered? One is cosmetic. Then
cosmetic, the contracture, they reaches more fibrosis and leading to more trismus.
Yes, they'll cause more trismus. What is local flap?
It can be a axial random flap pattern that's applied from a local region where it is either rotated, either as a transposition or as an advancement or a.
Okay, what is the advantages of local flaps?
It is less morbid, locally available. So the skin pattern, the color and everything matches with that region.
So long thin flaps can be harvested, okay? They're good in vascularity. And they'll have good contour, good texture match, okay? And donor site will heal easily, okay? They'll be less morbid. And you can do it fast compared to free flaps. What are types of local flaps, you know? Hello?
Yes, ma'am.
Yeah, what are types of local flaps, you know?
It could be based on various things, like based on the circulation, they can be random pattern or axial pattern. based on the composition, it can be either a myocutaneous or a faciocutaneous. And based on how it is made, it can be either an advancement or a rotation transposition, or it can be a local, or it can be a pedicle.
Random flaps में ही rotation, advancement, transposition, interposition flaps. Okay, all these are random flaps only. So random is skin and mucosal. Axial is, what is axial flap?
They have a single blood vessel with multiple.
So it has different blood vessels. From the area harvested. What are examples for axial flaps in head neck?
Forehead flap, nasolabial flap.
Yes.
Fram flap.
What flap?
Facial artery myocutaneous.
Temporalis flap has.
Yeah. So in head neck, what regional flaps are available? Leave alone your case. What are the regional flaps available for head neck lesions?
Forehead flap, nasolabial flap, submental flap, temporalis flap, buccal fat also, infrahyoid flap.
So cervical flaps, whatever you're telling. Okay. So nasolabial flap, suppose we take. Okay. So one of the most commonly performed regional flap. So nasolabial flap कितने type के होते हैं? And what is the blood supply?
There are two. They can be either a superiorly based or it can be inferiorly based. If it is superiorly based, it is based on the angular artery. If it is inferiorly based, then it is based on the labial artery, superior labial artery.
Angular branch of facial. Okay. So when is superiorly based nasolabial flaps used?
If it is for the upper lip, or if it is for the palate, or the defects on the
superiorly based.
Superiorly based.
Superiorly based means nose,
Nose,
nose, eyelid, cheek. Anything can be superiorly based. Inferiorly based when it is used?
Floor of the mouth, lower GBS, or if it is the lower lip that is involved.
Tongue. Tongue. Yeah. Yes. Floor of mouth, tongue. Oral commissure. Okay. Lower lip. Intraoral defects, basically. Yes. So, and what about the forehead flaps? What is it based on?
Forehead flap is based on superficial temporal artery. Anterior branch of superficial.
Trochlear artery.
Trochlear. Okay. So trochlear vessels it's based on. Okay. Superficial temporal artery based is transverse forehead flaps. Okay.
Yes.
So where are forehead flaps used for?
They can be used for any buccal mucosa defect, or if there is a bulky cheek involved. Nose, may eyelid, eyelid, canthus, nose, and you can use it for intraoral defects. Okay. Then what do you know about submental artery? Where is it used? Sorry. It is also used for tongue lesions, floor of mouth lesions.
What is it based on? Submental artery is a branch
of facial artery.
So, where is it used? What advantages and disadvantages it has got?
If the patient is a node positive, there is a bulky node, and the vessel might get injured, submental artery, while doing a neck dissection. So it might not.
Level 1A and 1B, it is better to avoid those things. Then, advantages?
It is a local flap, is cosmetically better.
Okay. So, a large area can be harvested and reliable pedicle also will be there. So, most of the oral cavity sites can be reached through the submental artery flaps. And
it's thin also, ma'am. Like for early buccal mucosa lesions, instead free flap we can do this.
So it is less time consuming than any free flap. Okay. So what will be when you harvest a submental artery? What will be the upper limit So your dissection should not go beyond that.
So chin.
Yeah, within the mandibular margin of the mandible. Okay, so then because it should be whatever your area of harvest should be hidden under the mandible. It should not be seen. Okay. Yeah. Next, deltopectoral flap. What do you know about DP flap? What are advantages and disadvantages?
It is usually used in a salvage setting. At present, like when the other flaps fail, DP is considered as a salvage flap. It can be a large skin paddle with a large cover. It can serve as a large cover and
has a good vascular supply.
Good vascular supply.
As you said, what is problem with DP flap?
Cosmetically, it is not so acceptable and it requires a two-stage procedure.
Stage procedure mainly. Okay. So then what are the myocutaneous flaps you know for head and neck reconstruction?
PMMC flap, deltopectoral flap. Different is this, or in a free flap, it can be even a ALT flap or the LT flap.
No, I'm asking local. Sternomastoid is myocutaneous only, no?
Yes, ma'am.
Trapezius flap? Trapezius also. Okay, LD flap?
LD trapezius.
Yeah. So, pectoral is myocutaneous. What is it based on? What is it? The arterial supply?
Pectoralis muscle. PMC flap is based on pectoral branch of thoracoacromial artery.
Anything else? Apart from thoracoacromial?
Lateral thoracic.
Of lateral thoracic also. So, PMMC you can use for majority, it's workhorse. Okay. Even full thickness defects of cheek, as in your case. Okay. You can use a bipaddle PMMC. When you do a radical neck dissection, okay, post irradiation, all this, okay, for protecting the carotid vessels, it acts as a cover. Even it can be used even for larynx, okay, so pharyngeal closure. And then platysmal flap, what do you know? So what is it based on? What is the blood supply of platysma?
Transverse cervicals.
Yeah. And? Okay, fine. What is the place where you cannot use a platysmal flap? Just think and tell. You know the answer. Just suppose you have done a section or you have given radiation to neck. Can you use platysmal flap? So that is the problem with it. Okay. So you have told no that I have not seen, because most of the patients require all this neck dissections and pre-radiated areas, so they cannot be used for reconstruction.
Yes.
Sternomastoid.
It is based on transverse cervical.
Sternocleidomastoid blood supply. Hello?
Yes,
Yes,
I remember.
Transverse cervical.
so it has segmental supply or only single supply?
Segmental supply, direct branches.
Segmental upper is from the occipital artery, middle is from the transverse, lower is from the transverse cervical, and middle is from the superior thyroid artery.
Yeah, so it has segmental supply. So problem with sternomastoid is it will not provide bulk. Okay, And what happens is when you do a neck dissection, no? So more so often you might damage the vascular pedicle. Okay, so any prior neck surgery or any lymphadenectomy, you cannot use the sternomastoid flap. Okay, but it is one of the, why I'm telling all this is sometimes they'll ask you what are the local flaps available. So just think as per where is the primary site of your lesion. All these are options. Okay. So whatever I have discussed.
Infrahyoid flaps, what places can we use infrahyoid flap?
Infrahyoid, I think you can use for floor of mouth.
Yeah.
You can use for floor of mouth to the extent I know. I've never seen an infrahyoid flap.
पर most of congestion हो जाता है. Most of the like.
So what about yes? So it is used mostly for any occipital region defects or parotid when you do a parotid surgeries. Okay, that area, because it cannot be mobilized to a longer distance. Okay, so can you repeat what all local flaps have told?
Tongue flap also be missed, no? Tongue flap is also used.
Yeah, tongue flap option.
मैम ये पैरोटिड से मेरे को याद है, ये स्मैश फ्लैप क्या होता है मैम? मैं तो कभी समझ नहीं आता.
Smash is okay. So superficial muscular aponeurotic system. Okay.
कौन सी लेयर से रेज करना, मतलब जो अपन रेगुलर करते हैं वो नहीं है क्या मैम स्मैश?
There is the this one the flaps in parotid, it is in the smash layer only. Okay.
जो अपन रेगुलर करते हैं वो.
हाँ, रेगुलर करते हैं.
Okay.
It is in the smash layer. Okay.
Okay.
Yeah, what was I asking? Yeah, repeat. Just local flaps. See, just remember this 5-6 flaps. So in your exam, whatever you have, they might ask, okay, when you tell most commonly PMMC, they might ask you what are the other flaps, local flaps available. So that time just think, keep it in your mind, all these flaps, and which are more like suitable into that area, you can say. Okay. So tell me all the flaps what I've told you.
Nasolabial flap, temporalis flap, submental flap, forehead flap, trapezius flap, PMMC, PP flap, platysmal flap, sternomastoid flap, and tongue flap.
Trapezius and tongue flap. Okay. So yeah, now tell me free flaps, what we use in head and neck. What is the advantage of free flaps compared to local flaps?
They are better. One, the bony segment also we get if we remove the bony segment. Plus, they are soft tissue bulk we can get, and the bulk and the cover is better with the free flaps.
So their reach is better. Okay, they're not like in any other local flaps. They're not restricted by the reach. Okay, so and good microvascular cover is there. Okay, skin, soft tissue, bone, everything can be reconstructed. So what are the free flaps you know which we can use in head neck?
They can be divided into osteomyocutaneous flap and myocutaneous flap. In osteomyocutaneous, it can be a free fibula flap or an iliac crest flap or scapular flap. And among the myocutaneous, it can be a free radial artery flap, ALD flap, or a free LD flap also can be used.
You can you use inferior epigastric tram flaps?
Tram flap can be used. EIEP flaps can be used.
Yeah.
Lateral forearm also.
Yeah, lateral forearm also can be used. Okay. So suppose mandibular reconstruction ke liye, like if it is central arch, okay, what is difference between the central arch and the posterior lateral or hemi, whatever you do? What is the difference in reconstruction? Suppose you need central arch resection. It's crossing.
Should get a bony reconstruction in case of a bone, lateral and posterior. I think, ma'am, we can use soft tissue also.
Anyone else?
These are morbid. These are very morbid.
Yeah, there is a
is to
deformity.
maintain the floor of the mouth, to maintain the disconnectivity between the oral cavity and the neck becomes important when it is a central, and also to get the angle, the cosmetically to get the chin.
So, do you use anything else apart from the flaps, free flaps? You use arch bars, plates, okay? For central arch reconstruction, you just cannot do with bone, okay? We have to use the implants, okay? These arch bars and whatever is, you have to fix them, okay, to either side. And as you told, there will be that connection between the floor of mouth and oral cavity. I mean the neck and oral cavity. And maxilla, what can you reconstruct with? What are all the options available for maxilla?
Maxilla is just an infrastructural maxillectomy, then a free radial artery forum flap is most commonly used. But if it's a total maxillectomy where we need a larger bulk, then a bigger flap like an ALT is preferred.
Okay.
Depends on the Cordero classification defect. In case of small defect type 1, we can just use an obturator. Larger ones we'll use ALT. And if we've gone till orbit, then we'll need something to support the globe.
Yeah. So what are types of maxillectomy? What's classification?
Maxillectomy.
It can be suprastructure, infrastructure, medial maxillectomy, subtotal and total maxillectomy.
Okay, there is any other classification that is for?
It can also be divided into suprastructural, infrastructural maxillectomy, or it can be divided into a total maxillectomy, conservative maxillectomy, and extended maxillectomy. That is the other classification. Or based on the approach for maxillectomy, it can be the endoscopic, transoral, transfacial, craniofacial.
Okay.
There's Weber, Ferguson,
Diefenbach. You know the distinction?
Horizontal, vertical classification is there, na, madam? That Brown's.
That is for defect. After maxillectomy.
There's a OK classification also, ma'am. OK classification and.
You tell me first, what is Ohensen's line?
Ma'am, it's a line drawn from the medial canthus of the eye to the angle of the mandible, and the tumors, which was originally for paranasal sinus tumors, and the tumors above this line are supposed to have bad prognosis. The tumors below this line are supposed to have better prognosis.
Okay. So now tell me the Brown's classification.
It has horizontal and vertical components. In horizontal component, if it is one will be in which there is both. If it's involving only the palate, then it's type 1. If it is sparing the orbit but going up to the entire maxilla, maxillary sinus, it is type 2. If it is involving the orbital plate, it is type 3. If it is involving the orbital plate and contents, it is type 4. If it is involving the orbit, if it is sparing the palate and it is orbito-nasal, then it is type 5, and I think nasomaxillary is type 6. And horizontal component is if A, B, C, and D. A is if it is not in, if it is a central defect less than 50%, then it is A. If it is involving anteriorly less than 50%, type B. More than 50%, type C. And involving more than one half is type D.
Okay. Any other classification you know, ma'am?
Cordero classification, ma'am, and OK classification. Cordero classification is 1, 2, 3, and 4. If only Cordero classification is if only maxilla is if the maxilla, there are 6 walls of the maxilla. If 4 walls are involved and the palate and the orbit are spared, it is type 1. If the palate is involved and and the walls of the maxilla involved, then it is type 2. If it is involving the orbital plate also, it is type 3.
So 2 walls. Okay. Type 2 is lower 5 walls will be involved.
Yes.
Okay? But lower than the reserved. And type 3 is total maxillary.
Yes, ma'am. Floor is also.
A and 3B, where orbital contents are reserved is A and removed is B, I think. Okay. So type 4 is orbitomaxillary. Okay. So yeah. So now what are the options available for maxillary reconstruction? Okay. First, what are the incision approaches?
Sorry, what are the
approaches?
Ma'am, the incisions can be per oral incision. We can use mid-face degloving, per oral approach. We can use Weber-Ferguson, lateral rhinotomy, which can be extended to Weber-Ferguson with subciliary extensions or superior extensions.
There is
Dieffenbach and Lynch extension.
Lynch extension.
Yeah. And any question mark of extension? Brief them. Yeah. Yeah. So, what is infrastructural maxillary?
Ma'am, it is removal. It is excision of the maxilla along with the palate below the infraorbital foramen.
So, yeah, another that total midfacial and deglobing. Yeah. So now, what are reconstruction options available?
Ma'am, one confusion I had in one book, it was written that we can approach infrastructural maxillectomy even by a midfacial degloving approach, but we always followed the Weber-Ferguson. So can we do it by midfacial degloving or sublabial approach for infrastructural maxillectomy?
What midfacial medial problem with the medial is not superior. So,
Madam, voice is not good. Voice cut हो रहा है.
Hello. Hello.
Voice cut हो रहा है.
I log again. Again.
Voice is not clear, ma'am.
Log in again. 1 minute. Now it's clear?
Yes, ma'am.
Yes, ma'am. Yeah. So, it's like for infrastructural maxillectomy, better it is like through Weber-Ferguson's. What happens in midfacial is like the superior and posterior extent you cannot reach. Okay. Technically, it is possible, but your reach will be limited. Okay, so it will be difficult. Okay, not that it cannot be done, but better is Weber-Ferguson's.
Okay.
इंफ्रास्ट्रक्चर का डेफिनेशन क्या बोला?
Infraorbital foramen से नीचे.
Okay.
एंटीरियरली लोकेटेड
So-
लीजन रहेगा तो मैम कर सकते हैं ना पेरोरल जो ये फेशियल
Yeah,
Okay,
anterior
anterior.
you can do. The most restriction in midfacial, okay, paroral you can do.
आई थिंक वो इंफ्रास्ट्रक्चर का वो भी है ना, ऑन ग्रेन लाइन से जो नीचे है वो इंफ्रास्ट्रक्चर है। आई एम नॉट कर रहा हूँ।
ऑन ग्रेन लाइन पे तो पता नहीं आ रहा है
जो है
ये
वो
फोरामेन से बड़ा है।
Yeah, it is na.
फोरामेन
From the canthus to the mandible. So it is below that.
इंफ्रास्ट्रक्चर।
Yeah, below.
कंफर्म करें।
Yeah. So what are the
Ma'am, in
options
case if
available?
we have a upper alveolar lesion, in that upper alveolar lesion which is invading the palate,
Both.
ma'am, is it appropriate that we say a peroral approach for such a lesion, because we have to do a proper infrastructure maxillectomy for that case? No, we
You
cannot
can do
do
that.
peroral.
You can tell peroral approach.
Sorry,
You can tell a peroral. You can tell peroral approach.
okay.
You can approach it through peroral. Abnet.
Ma'am, then how
ऐसा-
would we do an infrastructure maxillectomy in that case?
We can do. देखो दिक्कत ये है कि posteriorly located lesion is there, then the posterior cut will be little dicey in peroral approach. So if lesion is anteriorly, then we are not going to compromise posterior margins.
You can go through sublabial approach, वो cardwell look approach है ना, वो cardwell look take the alveolus down and you will reach the maxillary cavity and you take the hard palate also. Cardwell look approach.
Calval you. Okay.
Okay.
Yeah. What are the options available for reconstruction?
Ma'am, if it is only involving, depending on the Cordero classification, if it is only type 1, we can use ALT or radial free flap. If it is type 2, then it is further divided into 2A and 2B. If it is less than 50% of the palatal defect or more than 50% of the palatal defect. If it is less than 50%, we can use obturator along with some free flap. More than 50%, we have to use free fibula. And type, yes, ma'am. Type 3, in which we are taking out the orbital plate. Now we have to use either a fibula with titanium plate, or we can use tensor fascia lata along with the radial free flap. And in type 3B, when we've taken down the when we've done the exentration, then we don't need anything to support the orbital plate. Then we can do just a free flap, musculocutaneous free flap.
Okay. So just to remember it easily, if there are large surface area defect, okay, and with small to medium lesions, okay, volume is small, then you can use RAF or prefibula. Okay. If it is like large defects with large volume loss, okay, then you can use rectus abdominis free flap. Okay. If it is needing, if it is in need of orbital reconstruction, then you can use a bone graft combined with soft tissue flaps. Okay. And approaches for medial. Suppose if it is medial maxillectomy, then lateral rhinotomy approach will do. Okay. If it is
how do we define the medial maxillectomy? It is medial to what anatomical landmark?
Medial wall of maxilla, no? Medial maxillectomy is medial wall, involving the medial wall. If we have to defect, if you have to resect the medial wall of maxilla.
Okay.
Sublabial, all this, if they are large tumor with any parapharyngeal extensions and all, then use that sublabial and midfacial approaches. Okay, so that's about maxilla, mandible. So reconstructions of mandible defects, I think we discussed last time. Can you tell me that classification of mandibular defects? Type 4A, 4B, 4C, 2B, 2C and 2, 3. What is that classification name?
There's Boyd classification and then there's Brown classification.
Yeah, tell me Brown's classification.
So Brown classification is based on the 4 points in the mandible, 2 canines and 2 angles. So if class 1 is when the defect is involving only one condyle, one angle, and then if that is 1A, and 1C is includes condyle also, and 2 is one angle and one canine, and 2C is along with the condyle. 3 is when both the canines are involved. 4 is when both the canines and the angle is involved. At least one angle is involved. And 4C is with the condyle.
Yeah. So 1 is more lateralized defects. Okay. So if it is if it is lateralized defect with condylar excision, it is 1C. Okay. If it is hemimandibulectomy with excision of the condyle, it is 2C. Okay. And if it is anterior resection, means both canines on either side, that is anterior arch resection, it will be class 3. And class 4 will be 4C will be including one of the condyle. Okay. So all this again differ based on the size. Okay. What is the size of excision?
Ma'am,
Okay,
what is this classification referred to as?
Brown.
Okay.
There are many classifications for mandible. HCL classification. Okay. Then urban classification. So many classifications are there, but most commonly followed is Brown, okay, and HCL. HCL in the sense hemimandibulectomy, central lateral mandibulectomy,
Central defect and lateral defect.
okay, HCL. Yeah. So what about the defects reconstruction based on this Brown's classification? What is the classification which told about the reconstructive options in relation to the defects produced in mandibulectomy? It starts with S.
Spiro, ma'am. Spiro
Hello?
classification.
Not Spiro. What did Spiro et al. Tell? What is Spiro et al.'s paper?
I think it was for maxillectomies, ma'am.
No, it was not for maxillectomies. Tell me. This is Schlatz et al., if I'm not wrong. Okay. So it has told about the amount of the mucosal bony defects and based on that reconstruction. Okay, Schlatz et al. Paper.
Just link spelling. What is the spelling, ma'am?
SCHULTZ, I think. Okay.
Okay, thank you.
So, what are all the options available for you for reconstruction of mandible, Dishita? Hello?
For reconstruction of mandible,
Yes. Suppose start from where they don't require a reconstruction. What are those defects?
Marginal.
Okay, marginal में कितने types है? What are
horizontal,
types of
vertical,
marginal
oblique, and reverse.
Vertical, horizontal is also there.
Vertical, horizontal, oblique, and reverse mandible.
Okay, this where all it is indicated, no? We have discussed last time. Reverse is?
Reverse is when there is a node which is causing erosion on the lower border of the mandible.
So, what are the local flaps that you can use?
You can use a tongue flap, you can use a masseter flap for a marginal mandibulectomy, or a buccal fat flap,
Can you use a nasolabial?
We can use a nasolabial flap.
Floor advancement.
Submental.
Forehead.
Floor advancement.
Forehead.
Hello.
Yes, ma'am.
Yeah. Among the local flaps which we discussed, what are most suitable for mandibular reconstruction? Now only we discussed no local flaps. Among that,
mandibulectomy, nasolabial or a temporalis flap, and if it is anterior, then even a submental flap can also.
Okay. Regional flaps?
Well, it is a segmental mandibulectomy. In those cases, PMMC flap.
PMMC. Then? Did you tell tongue flap in local?
Yes, ma'am. Tongue, masseter flap and also buccal flap.
Yeah. So, in local regional, regional flaps?
PMMC, DP flap.
When will you do staged procedure for DP flap? Suppose you have done it today. After how many weeks you will disconnect the pedicle?
2 weeks.
21 days.
3 weeks.
3 weeks. Yeah, 3 weeks. Okay. Yeah. Then forehead flap, can you use?
Yes, ma'am.
Yeah. So what will be your goals of reconstruction in mandible, Dishita?
For the one is to maintain the continuity of the bony segment, get a dental rehabilitation on a later date, and to match the mandibular height if you're using a bone, and to the normal position of the condyles should be maintained and the oral sphincter should be maintained.
Okay. So it's also like it should be functional. Okay. So then yeah. So what all flaps can you use?
We can use a prefibula flap, iliac crest flap, radial artery osteocutaneous flaps can be used, scapular flap can be used, or a pedicle flap like a PMMC flap also.
Okay. So do you know anything about immediate versus delayed reconstruction, which is useful? When do you consider for delayed and when you consider for immediate?
If it is a post-radiation patient with previously received RT, or if it is a recurrent lesion, those patients a delayed flap can be considered.
So where you think, like in your case, where you think margins would come positive, but you're going for surgery, okay? So you have section may not give you fair idea, okay? In this case, especially when involvement, so not much. So that
your voice is breaking.
Voice is breaking, ma'am.
Voice is breaking, huh? Okay, I'll again log in, huh? Give me 1 minute. Can you hear me now?
Yes, ma'am.
Yeah. So, thing is that immediate reconstruction is the most preferred one. Okay, because it will avoid. It improves the quality of life first of all. Okay, and the next whatever treatment you give, it might cause scarring and all. So the uptake, the take of the flap later may not be so good as when you do it immediate reconstruction. So reconstructive options will be what one you told, flaps. Okay, there can be like osteocutaneous flaps or osteomyocutaneous flaps, or they may not, yeah, they like a pedicle flaps. Okay, they can be free bone grafts or vascularized bone grafts. Okay, apart from this, anything else for bony
Plates.
have you
Benign
seen
lesion.
for distraction osteogenesis?
Yes.
What is that?
Ilisaro.
Yeah, it is something similar to Ilisaro. What happens in that?
We leave a gap, then apply contract, like with gradual time we decrease the gap and the bone will grow like that. Distraction and osteogenesis basically.
Yes.
They do
Close.
osteotomy and then give a brace and then.
Yeah. So it's like new bone formation is allowed. Okay. When there is distraction between the two bone surfaces. Okay. So that segment of that osteotomy is done, and that by mechanical device they will distract the two ends of the bone. Okay. Then new bone fills up in that area. Okay. So then what is alloplastic, that alloplastic mechanism of reconstruction in
just plates are placed to connect the two segments and no other reconstructions.
Yes. So this reconstruction plates are used to stabilize the remaining parts. Okay. And okay, now can you tell me, like based on what defect you will read Sludge et al. And tell me, or you want me to tell?
We'll read it.
Yeah, read and tell. Okay. So it again classifies it based on osteomyocutaneous and all. Again, it will divide into A, B, C, D. Okay. So you read and tell. Okay. Then yeah. So this is about reconstruction of mandible, maxilla. Okay. And for skin, you can use a bipedal soft tissue. All the myocutaneous flaps, whatever. So now, what is the problem with this? So for each of the things what we have discussed, okay, how will you rehabilitate? And one more thing, you should be aware of this. When flaps are asked, no, that what is that classification? Matthees-Nahai classification.
Matthees-Nahai classification.
Do you know that?
It is based on the vascularity, where it has five groups where it is divided. First one, class 1, it is where there is just a single vascular pedicle. Class 2, where there is a one dominant and minor vascular pedicle. Class 3, where there are two dominant pedicles. Class 4 is segmental. Class 5 is dominant with multiple secondary segmental.
Okay, where does the spectralis major come?
Spectralis major is type 5. It has one dominant and multiple.
PMMC, LD, okay, all these come under type 5. Okay, the type 1 will be this tensor fasciolata, okay, flaps, and type 2 will be gracilis and soleus. Okay, the rectus abdominis and all this flap will come in type 3. Okay. And what is septocutaneous perforators based classification? What is the name of that? Whether it is direct septocutaneous, direct cutaneous perforator, or musculocutaneous, what is the name of the classification? Nakajima. Okay, Nakajima classification. Okay. Then yeah. So now you tell me what. So in this case of yours, okay. So suppose considering you have done an infrastructural maxillectomy with a hemimandibulectomy, okay, and skin you have dissected that part of involved or suspicious skin involvement. So what is your ideal flap here?
Bipedal PMMC would be an ideal flap.
Why your patient is fit? No. Don't take monetary things into consideration. Just ideal flap I asked.
It would be a dual flap.
Okay, accepted. Composite.
Composite flap, a free fibula osteophytemus flap for the mandibular as well as for the defect, and maybe a free radial artery flap for the infrastructural biselectomy.
Bipedal this fibula also.
Fibula means you have to take somewhat more of soft tissue extension.
Yeah, bipedal fibula.
That's what. To get a bipaddle on a free fibula flap, it is not routine. So you have to take a little more length of soft tissue, okay, to get a bipaddle. Or other option could be a free fibula with a PMMC, okay, to cover the soft tissue defects. If nothing, patient is not fit and all, bipaddle PMMC also will do, okay? Fine. So what are the problems you anticipate? What are the rehabilitation protocol, rehabilitation you look at in this case?
Post-operatively, swallowing and for the trismus, patient might need a rehabilitation for the mouth opening.
Okay. When will you start exercises?
Once the patient completes radiation, 2 to 3 weeks after the patient has completed.
Once patient complete radiation.
Yeah, adjuvant RT. This patient will definitely need adjuvant RT. So once the adjuvant RT is completed, 2 to 3 weeks after the post-radiation mucositis and all that.
Too long, na? I think 3 weeks.
Let her tell, no? Yeah, tell Rishita, what? Why you want to start?
Because post-op, even during radiation, most of the patients will have mucositis and everything, so they are not usually compliant for these.
But once you give radiation, no, their fibrosis will set in. Okay, it is very difficult to convince patient to do that exercises what they have done, not done in post-op, to do post-radiation. Okay, if you wait till post-radiation, contractures will set in. Okay, so ideally you will not wait till post-radiation. When will you start?
Once the flap has healed, maybe 1 to 2 weeks after the.
As soon as you start oral feeds, we should start, no?
Yeah, 8 to 10 days later. Okay, so that is the ideal time. Okay, so suppose in this case you will put in a Ryle's tube, no, Dishita?
Yes, ma'am. Yes.
So would you like to do a tracheostomy?
If it is
no means no, that's it.
No, ma'am.
Yeah, you tell it's not that posterior defect that might need a tracheostomy, right? So if it is more of tongue, posterior tongue, okay,
more of mouth, or if it is a middle third defect, where the fall of tongue, or if it's a bulky flap where a tongue fall is expected.
Yeah,
those cases I will do.
Those cases you will need. So yeah. So then what else? What else rehabilitation you are bothered about? Early post-op, I'm asking.
The swallowing. The patient might need Ryle's tube feeding for a longer time to maintain a nutrition and eventually get a speech and swallowing therapist to see the patient.
When will you get a speech and swallow rehabilitation started?
Within a week, 1 week after surgery.
Is it pre-op or post-op?
We should ideally start with the pre-op itself before the surgery, and immediately after the surgery within a week we should start.
Yeah, should be started pre-op. Okay, it should be counseled about all the possible defects that can. Okay, can you tell me what are the phases of swallowing? I think last time I asked that I will ask this time. Okay. What are phases of swallowing? Anyone? What are phases of speech and what are phases of swallowing? किसी ने नहीं पढ़ा? Last time बोला था ना?
थोड़ा याद है लेकिन डिस्क्राइब करना मुश्किल है. ओरल पेरिंजल
ओरल प्रोपागेटरी ओरोफेरिंजियल ऐसा मतलब पूरा एग्जैक्ट किया.
ओरल पेरिंजल एंड इसोफेगस. क्या होता है वो याद है.
Swallowing में कितने phases हैं first? 4. Yeah, what are those?
Preparatory, oral,
Pharyngeal,
esophageal.
Okay. So which are voluntary, which are involuntary?
First preparatory and oral is voluntary.
Pharyngeal and esophageal are involuntary. So you expect any swallowing difficulties in your case, Dishita?
Yes, ma'am.
Whatever. Okay. So which phase do you think would have been affected?
The second phase, the oral phase, for the movement of the tongue, movement of the food inside the oral cavity and pushing it into the oropharynx.
Why not preparatory phase?
Even preparatory, the first and the second phase.
Yeah, first and second, both will be affected. Okay. So if it is tongue, posterior third of the tongue and all, then it will be pharyngeal phase as well. Okay. Pharyngeal and oropharyngeal, esophageal phase. Okay. So what precautions you want to take? What you will explain him and what is the food you start with?
Initially start with a liquid food so that the patient is counseled for the movement of the liquid food in the oral cavity and pushed into the oropharynx and eventually to the semi-solid followed by the solid food.
Sipper will sip.
With a straw or a long spoon is used for the patient to help to backwards.
Okay. So now you understand why we should do the exercise. We'll start the exercise. Yeah. So yeah. Then what are okay? This phases of swallowing and types of feeds are important. Okay. So when do you remove the Ryle's tube?
We ideally ask the patient to start with the rehabilitation for the swallowing and everything, and once we are sure that the patient is at least able to swallow liquid food, then we remove the Ryle's tube. Roughly around 4 to 7 days.
Sorry?
From day 4 to day 7.
Extent is will decide, na ma'am.
That patient
Anterior
is
or posterior.
Able to swallow liquids without coughing or without aspiration.
Yeah. So you look for, is there any cough on giving liquids with their Ryle's tube in situ? Okay. If they are coughing, then you will not remove the Ryle's tube. That means the swallowing reflexes have still not they are not into the full extent. So you will wait for some time. Okay. If there is a cough reflex on giving liquids. Okay. Then yeah. So what are speech things that of course not related to your case? I'm just asking what are the speech defects that can be caused? I mean, what are the phases of speech? Hello?
Oh,
am I audible?
Yes, ma'am.
I'm audible. Okay. So you told something last, some cephalic, something you were telling, no? Articular phase. Sorry?
I don't know the exact.
There is a source. That one, madam. Source, resonator.
No, that is for larynx.
No, not that. The phases of speech.
I'll read and tell.
Okay. So initiation. Okay. The phonation, oronasal, articulated speech. Okay, all these are phases. Okay, you read and tell. Okay.
Yes. Yes.
So yeah. So just because we have discussed maxilla mandible, can you tell me for tongue also what are the reconstructive options available and what classification the defects were?
Answerine classification.
Yes.
Type 1 only mucus resection, type 2 muscle, type 3A hemiglossectomy, type 3B compartment, type 4 near total glossectomy, type 5 total glossectomy.
Type 4 में फिर से है ना?
टोटल नहीं है
दोनों में ना 3 में भी है 3B 4A 4B.
If both BOT is preserved, then it's type 4A. If only one BOT is preserved, then it is type 4B.
near total, subtotal near total.
Anterior what?
Subtotal is anterior and near total is only one BOT left.
So what are types of reconstruction that you do in a tongue? So just to summarize what she told. Type 1 is mucosectomy. Okay. Type 2 is partial glossectomy. And type 3 is hemiglossectomy. Type 3 is hemi and type 3B is part. Okay. Type 3 is subtotal and anterior. Okay. Type 4B is near total. Okay. And type 5 is total. Okay. Yeah. So how do you reconstruct the tongue lesions?
For type 1, if the defect is less than 1/3, even a primary closure or healing by secondary infection can be done. For the type 2, or when the defect is between 1/3 to half, we can either do a primary closure or even a flap, like a pre-radial artery flap or a pedicle flap can be used. For a type 6 defect where we have done a hemiglossectomy or a compartmental resection, PMMC or a pre-radial artery forum flap or a ALT flap can be used. For a type 4 where it is near total or a subtotal, where the bulk required is a lot, where a bulky flaps like ALT flap or a PMMC flap can be used. Type 5, with this total glossectomy, again PMMC or radial artery flap or a double flap also can be used.
Okay. So whenever you require bulk, it is ALT. Okay.
Yes.
So when you want a little less bulk, like in posterior third defects, you can even thin out ALT at a later phase. So, but ALT is ideal when you require bulk. When you don't require bulk, but like in hemi, RAF can be used. Okay. So other than this, PMMC can be one option. Okay. Not very ideal, but it can be used other than free flaps. Okay. So yeah. Anything other than this? Reconstructions? So rehabilitation is important, okay?
Yes.
Next time anyone is presenting head neck, okay? You have to tell me all phases of swallowing, speech, and what is affected in what resections. Okay?
Yes, ma'am.
Okay.
That's it. Anything cheek defects के लिए buccal mucosa you can use local flaps. We discussed all that. Okay. Just have the basic idea what are the local flaps available, what are the regional flaps, and what are the free flaps available. So based on your site of lesion, you have to tell like what are the ideal flaps there. Okay. What we discussed in the first half, no? So I have that all flaps tell according to the site of the lesion. Okay.
Yes.
So
I have a doubt. For the dental prosthesis, what is the time that is?
What about that rehabilitation? Yeah, when will you ask for dental rehabilitation? I mean, when will you start thinking about dental rehabilitation? reconstruction.
1.5 to 2 years after completion of RT, or like
Minimum of 18 to 24 months. Okay. So
yeah.
generally 18 to 24 months. Okay. So ideal is nearing to 2 years. Any time you have to ask for dental rehabilitation. Why?
post RT there is high risk of ORN or some infections or fracture if we are trying to do anything with the bone.
Yeah. So because of the fear of osteoradionecrosis. Okay. So anyone can tell what are the types of osteoradionecrosis grades?
Cars classification.
Yeah, tell me.
In first there is symptoms only, madam. Symptoms, and second there is pain with discharge. That's not wrong. In third there is fracture, I suppose. Not exactly remember, but like K say classification. Car classification, something like that.
What happened? Just describe it. No need of.
Hello?
Yeah. Are you able to even? Hello.
Madam, why? Yeah, madam. Tell me.
So what is the defect in speech? Telling correct only. Tell.
Yeah, madam. In first there is there is only pain, madam. In second there is pain with discharge. In third there is fracture.
Yeah.
Right.
Correct only. Okay. If it is confined to the dentoalveolar bone, okay, only symptoms, there are different classifications, okay, of which what he told is one type, okay. So if it is improved through conservative measures, okay, or any antibiotics or local debridement, or
oxygen, hyperbaric oxygen.
That's stage 1, okay. Stage 2 will require all the conservative measures, but will require any
antibiotics also.
And third stage might require hyperbaric oxygen, okay. So that is based on treatment, okay. Then if it is confined to alveolar bone, it is 1, okay. If it is involving the inferior alveolar canal and all, it is 2, okay. If it is forming fistula, all those things, it is, and fracture, it is type 3. Yeah. Anything else you want to discuss? I think we are, in first 2 classes we have discussed all the neck dissections, and we have discussed. Somebody told me like they will tell the boundaries of neck dissection and all. Have we discussed that last class?
Boundaries, mostly I think we discussed some part.
Yeah, I think we discussed neck dissection and what we should resect when tongue was presented.
Yes, ma'am.
Anything else in the head neck? Anything grossly we left? Not to discuss now.
I'm very glad we are discussing.
Very happy.
Parotid is one potential case. Okay.
Parotid and thyroid.
Sorry?
Parotid and thyroid we are left with.
Yeah, thyroid, Sana told she'll present, no? So
Parotid, I have one case, but it is of not pure parotid. It is a GBM of parotid.
I have a parotid case. But
I give you. I have a parotid case. So you take someone present, then we can discuss. Okay.
I took that parotid lesion. It's a parotid lesion, but its histopath is GBM. So
GBM.
glioblastoma multiforme, ma'am. Patient was
GBM
having
primary
brain malignancy 2 years back, and now it's presented as a parotid lesion. So I was
Okay,
not.
I have your so you can, if you want, one of you can present. Yeah, I'll send the PPT.
Okay, ma'am.
Sana is presenting thyroid, so one of you can. Okay. New people. Apart from they're all presenting all through documents. People come from
New
again.
people
You will not.
is Dr. Divyang and Dr. Ishfaq and Dr. Mohan.
Present testes, madam, in next coming days.
Testis you will present. Okay, fine. Not see that you should present the cases which will come next. It is just to lose the fear of presentation. If you can present me, I'm like your friend only. If you can present near me, with me, like without fumbling, then you will practice. Okay. But to present to someone else or at the time of examination, you should not be blocked.
सॉफ्ट टिश्यू सार्कोमा भी रह रहा है मैम सॉफ्ट टिश्यू सार्कोमा
हाँ सॉफ्ट टिश्यू सार्कोमा ले लो okay soft tissue sarcoma में we have to discuss that grades and all last time it was bone में थोड़ा बहुत but soft tissue is a potential case so especially if it is thigh thigh and leg any soft tissue you have you can present
एब्डोमेन मैम हम लोग का हो गया है ना
एब्डोमेन लंप हो गया
RIF बचा है RIF लंप बचा है आई थिंक किडनी हो गया है ओवरी हो गया है
RIF also I did RIF
he presented no
RIF I think कुछ नहीं बचा
actually I'll tell you left
retroperitoneal mass
tumors none of them are presented they can come okay SCC can come melanoma though rare if they have one case they'll put okay so then SCC of extremity is quite common especially if you get your centers in medical colleges no? You will get one SCC extremity if it is there okay so that is one potential case the second what you have left in head neck is thyroid parotid and CUP okay so CUP is more of a theoretical discussion but still if they don't have cases they can put okay but make sure you present thyroid and parotid okay these are potential cases in GI we have done stomach esophagus unlikely but it will be part of your table viva okay so it's also more theoretical yeah so colon rectum we have done stomach we have done okay small bowel unlikely okay and right iliac fossa it can be like appendicular masses sometimes they'll put this to discuss about the peritoneal pseudomyxoma peritonei or like that okay so if they don't have cases and retroperitoneal sarcoma if they have one they'll put okay generally patients will be in distress so they will not prefer put and then genetic
your voice is breaking ma'am
now
better
yes yeah so gynec we have covered endometrium won't come so cervix and ovary we have covered so in genitourinary we have covered penile we have covered renal okay so testicular is left so issue will present testicular okay
issue
urinary bladder
HCC is left HCC left
yeah in hepatobiliary pancreas gallbladder we have discussed so HCC is one potential thing like so you have some 5 potential cases thyroid parotid HCC
soft tissue
sarcoma and what do you say HCCs okay RPS and all are there but they're rare I won't say this case won't come if they don't have any cases they can put any case but that's why you know a little about every case but may not be like you should tell 100%. If they put a rare case, they don't expect you to tell 100% also. Okay?
प्रोस्टेट भी रख सकते हैं
कौन सा?
प्रोस्टेट
प्रोस्टेट नहीं
Prostate they won't put. They won't put.
pulmonary bladder
No.
Okay.
See what visible they'll put. Okay. For surgical oncology, they will put what is visible. For medical oncology, even though they don't tell clinical findings, they will only ask theoretical questions for them. So for us,
lymphoma and leukemia also they will put for them
for them it is like only medical discussion options of treatment available. For us, it is not like that, no. So we have to examine. Vulva is very rare. Okay, so that is very rare.
Larynx?
Larynx, they'll ask you in table by wire. And I don't know if they'll put, but none have got from our batch. At least none have got larynx.
I have presented larynx.
Yeah, you know, you are one.
Laryngologist.
She will tell examiner only, you don't know anything. That's good only. I don't know anything in larynx as such.
I was also not knowing before presenting. For presenting, I presented 3 people, and I got 3 people have different questions in each presentation. The knowledge में exaggeration हो गया.
Okay, so that's about head and neck. So
24th, ma'am, I'm leaving India. So उससे पहले, if possible, I will present one. उसके बाद I am coming back on 31st.
Okay, you will join for online.
Exam आ गया तो बीच में?
Hopefully नहीं आएगा.
Don't say that. It's okay. It won't be before 29th, I feel.
अभी तो मैम सेकेंड का भी आ गया ना. सेकेंड में है आई थिंक गायनेकोन को 2 अप्रैल आ गया है. तो 2 अप्रैल तक नहीं होगा, उसके बाद होगा अब जो होगा.
It will be in the first week or second week of
अप्रैल. सेकेंड वीक मेरे को लग रहा है, बिकॉज फर्स्ट वीक में MCH वालों का 2-3 जगह पे एग्जाम है. टाटा, किदवई एंड Osmania and RCC Trivandrum also.
Our examiners, very few are MCH examiners, like Srinivas Lusar or this what is his name? I'm not getting it.
Arvind Krishnamurthy sir.
Vijay sir.
Kumar sir and Arvind Krishnamurthy sir. So
पर
these are
Arvind Krishnamurthy sir is free because ADR का एग्जाम हो गया है.
It depends. NB we can't predict anything, but you people be prepared by this end of month. Try to cover all the topics. Okay, wherever everyone, each one of you will know where you are weak. So try to revise that more. Okay. Your individual preparation is different. What we discuss in group is different. This is just to help you. Okay, but your individual planning and preparation should be, each one's is different. Somebody's head and neck, somebody is weak in breast. So identify where you are weak in and keep presenting in front of mirror. Okay, because to all those who have not presented till now,